دكتور محمد ما يبقى مع حضراتكم ومع الاسم كله. I hope we won't bore you today. This is our second day زي ما حضرتك بتقول. And this is not meant to be a technical talk as such, but mostly focusing on the general principles guiding CTO PCI, given that it is indeed an area where increased interest on the whole is rising, and where we're progressively seeing more patients who can benefit from CTO techniques on the whole. So these are my disclosures to get them out of the way. I just want to start with a couple of minutes by Andreas Grunzig back in 1982. And that was insightful to listen to what he has to say almost 40 years ago about CTO PCI.
Like to depart on more total closures and try to learn how to deal with total closures, how to approach total closures, and to learn how to technically recolorize total closures. As you know, in peripheral dilatation, we do this all alone. Charles Stoddard did it in 1965 or 4, that he crossed the total closed iliac artery with a guide wire and pushed his coaxial catheter through, as he did it also in the SFA. Therefore, to cross total closures is not a new experience for me. I've known this since 15 years now myself. But the femoral artery is a different story than the coronary artery due to its anatomy. It's a nice straight line down the road, and you push the guide wire. And if you're lucky, you find a distal lumen. If you're not lucky, you just finish the procedure. That's not that easy in a coronary because the heart, as you know, is beating, and you have curves drip.
So this was insightful in all honesty, because this is almost 40 years ago, very early on in the history of PCI on the whole. And Andreas almost had the vision to see that this is an area where we will have to conquer. He acknowledged the challenges quite rightly, and he quite rightly pointed to his previous experience with peripheral interventions, which has mostly guided current strategies for CTOs in the coronaries as well. So it was eye-opening to listen to this. Now, this was a white paper we worked on. These are 101 operators from 50 different countries. And this is meant to highlight the key components of CTO PCI. And the essential thing is to highlight that this is now being done more or less in a similar fashion on a global level. So it is no longer an esoteric technique mastered by a few individuals who happen to be doing things that don't really add up or are fully understood by everyone. So we have a more or less algorithmic approach. So we have 7 key principles. The first is obviously understanding the indication of the procedure. The first is obviously understanding the indication of the procedure, and we totally understand that synonymous and similar to the rest of stable coronary artery disease interventions, improvement of symptoms is our primary objective and the primary indication. And we do have 4 randomized trials in this arena looking at different endpoints. I just quickly want to point your attention to the fact that the currently available data, or the current available data, do not support CTO PCI for prognostic indications. But that perhaps is mostly due to the poor quality of the evidence available. So if you look at one of the bigger studies, which is frequently cited, Decision CTO, a South Korean study, we will immediately realize that this was prematurely terminated after recruiting only 2/3 of the number of patients initially intended to. 77% of the optimal medical therapy arm eventually ended up receiving PCI. So there was to a non-CTO vessel. So there was a huge overlap in terms of PCI. The distinction was whether this was PCI to a CTO vessel versus PCI to a non-CTO vessel. There was also a 20% crossover rate from the medical therapy arm to the CTO PCI arm, and symptoms and residual ischemia were not routinely evaluated after performing a non-CTO PCI in the same patient. Similarly, if we look at the Explore trial, the Explore trial looked at ejection fraction and end-diastolic volume before and after the procedure. And the first thing that strikes you is a huge selection bias. This study took 7 years to recruit just above 300 patients from 14 sites. So it seems, and these were pretty much high volume centers, so it seems that there was a lot of selection going on, with the more deserving candidates as per the operator's decision receiving CTO PCI without being randomized or enrolled in the study. Again, symptoms and ischemia and viability were not tested, and the PCI success rate was quite close, 73%, which was quite inferior to what we're accustomed to in the current era. The Euro-CTO trial again tried to look at a primary endpoint of quality of life, and again similar problems, prematurely terminated after recruiting only 1/3 of the initially intended number of patients. Many highly symptomatic patients were not randomized. Again, at the operator discretion, the more deserving candidates were electively put to the CTO PCI arm, and hence were not enrolled. And PCI to CTO vessels were performed at least 4 weeks after PCI to a non-CTO vessel, which is a huge advantage compared to what happened in decision CTO, and the crossover rate wasn't the greatest. And with Euro CTO, we did manage, acknowledging the underpowering, we did manage to see a significant difference in terms of quality of life in favor of those undergoing CTO PCI. However, if you look at different meta-analyses, you see that these are almost 40,000 patients from different non-randomized studies, as well as those 4 randomized studies. And you can see that there's a significant net gain favoring CTO PCI in favor in terms of all-cause mortality and cardiac mortality. And we do acknowledge the limitations of the meta-analysis, especially that the results were largely driven from registry data and non-randomized trials. But again, this emphasizes that we simply don't have the quality of evidence to give us a clear way forwards. However, this is the guideline indication. We have a class 2A recommendation for CTO PCI to patients with angina that is resistant to medical therapy, or with evidence of a large area of documented ischemia in the territory of the occluded vessels. Now, obviously, we don't know what will happen to this recommendation in light of the ischemia trial, but again, we'll just have to wait and see, acknowledging the very specific cohort of patients ischemia was looking at. But I want to draw your attention that sometimes this sort of procedures becomes life-saving and does derive prognostic implications or have prognostic implications. And similar to or synonymous to other interventions, case selection is fundamental. Being able to discern which patient is going to benefit from occasionally aggressive techniques is crucial to everything we do when it comes to intervention. So this is a 55-year-old gentleman, smoker, hypertensive, diabetic, chronic kidney disease with moderate affection, status post-cabbage 6 years earlier, receiving 3 grafts, angina and mild exertion, mild reduced ejection fraction, but not in congestive heart failure, underwent a multi-slide CT, which showed an occluded lima to the LED, as well as occluded venous grafts to both the RCA and obtuse margin branches. CMR showed viable myocardium in all territories, and this was diagnostic angio performed 15 months prior to his presentation to our center. And on the left-hand side, you can immediately appreciate that there is a tight subtotal lesion in a circumflex, which happens to be the only patent vessel on the left system. The LED is totally occluded and fills faintly close to the apex. If you look at the lateral view, you can again appreciate very tight lesion of the circumflex with a reasonable distal LED, albeit with a lot of disease in the mid and proximal segments. On the right coronary artery, totally occluded vessel, and we can't really see any flow antegradely, but we can appreciate from the previous slide that the RCA fills retrogradely via branches, septal branches from the LED essentially. And you can see the RCA here. Totally occluded lima. So that was similar to what the CT told us. And this was the PCI or the angiogram 15 months later when he presented to our center. and it hadn't really differed from the diagnostic angiogram. Again, tight lesion, the circumflex. You can see a decent sized PDA and PLA filling retrogradely both from the LAD and distally via a tooth marginal branch. And you can appreciate again an LAD which seems to be slightly worse than the previous diagnostic angiogram. I don't want to get into the technical details, but the description we have in mind: two complex lesions with ambiguous proximal caps. The RCA lesion has the distal cap at the bifurcation, which adds to the complexity. The LAD has some distal disease, good collaterals from, albeit from an epicardial vessel coming from the circumflex, which has a lesion, a high-grade lesion in its own, and a very long lesion length in both vessels. So with such complex anatomy, the best thing is to have a stage procedure with the LCX fixed initially, followed by the LAD, followed by the RCA after a period of time. And the plan was to go initially retrograde through, fix the circumflex, fix the LAD retrogradely via the circumflex after stenting that high-grade stenosis, and addressing the RCA again via primary retrograde strategy in another session. And direct focal stenting to the circumflex lesion, followed by a cyan black wire aided by a turnpike LP micro catheter through the tortuous epicardial collateral. And again, I'll go quickly through this. You can see that the micro catheter is now retrogradely sitting in that in the mid LAD, and then we dissected retrogradely with the knuckle, performed a reverse cut in the proximal LAD, externalized the wire, and ended up putting 3 stents in the LAD with this final result. Now, this was a 90-minute procedure, 3.2 grays with 220 cc's of contrast. And 2 months later, we went for the second procedure. And the good thing about staging procedures with such anatomy is you will now find septal collaterals that are well developed from a now patent LAD, and this would serve as a much safer retrograde route to the right coronary artery rather than going through the very tortuous epicardial collateral through the AV groove. And again, that was relatively straightforward going through that septal perforator. We now have a Corsair micro catheter sitting just proximal to the bifurcation in the RCA. Going retrograde with the knuckle, you can appreciate that the knuckle initially went into the saphenous vein graft rather than to the proximal part of the right coronary artery. So we had to dissect antegradely to try to resolve this coarse ambiguity. And now we have the two systems overlapping at the mid-RCA. We had a bit of resistance here because of this is not infrequently encountered because of the site of anastomosis of the saphenous vein graft. Frequently causes a lot of fibrosis besides the sutures. So it's difficult to overcome that. One way to do it is via contrast-enhanced microdissection, which is called the Carlino technique. And doing that, we were able to advance the antegrade gear, perform the reverse cut in the distal RCA, salvage the PLA, which now has a dissection at its origin using a dual lumen microcatheter, and ended up putting, I think, 3 stents all the way from the proximal right coronary artery into the PDA with only a drug-coated balloon at the ostium of the circumflex. So this is a relatively young gentleman, 54 years old. This procedure was around 2 years, 6 months ago. We just saw him a couple of weeks ago and he's in perfect shape. He's enjoying his life, he's back to work. And we think that this is the sort of patient that can derive significant benefit both in terms of quality of life and prognosis using such techniques. So the second key principle is dual angiography. And dual angiography comes with a clear and deep understanding of the coronary anatomy, including the length of the CTO segment, the proximal and distal caps, the distal vessel or the runoff, as well as the collateral circulation. And to do this, the only way is really using dual angiography. And this is not something new. This was actually described years ago, almost 20 years ago, by David Holmes and the group at Mayo Clinic. And this was, again, while not focused on CTO, PCI as such, but it was focusing on the utility of bilateral injections to understand anatomy during complex coronary angiography. And we just discern a number of key points with dual injections. We start by the donor vessel first. We don't do any magnification because you don't want to lose temporal resolution when you do a lot of panning. So the key is no magnification, no panning, and we inject starting with the donor vessel. And we keep cine until the dye reaches the distal cap. Then we inject the antegrade route or the CTO vessel. And the key thing you want to see is contrast filling both the antegrade portion of the vessel proximal to the CTO segment, the distal segment of the vessel, while simultaneously visualizing both the proximal and distal caps. And those are really the four key features which we're looking for. What does the proximal cap look like? Is it blunt? Is there an entry point into it? Is it totally ambiguous because of severe angulation or tortuosity, or more frequently because it comes at the origin of a side branch? What is the lesion length? And do we have any tortuosity in the segment? Do we fully understand the course of the CTO segment? And whether there's any calcification, the distal vessel, is it diseased or healthy? And what are there any interventional collaterals as such? And what exactly is the root? And the reason we look at this is trying to understand the best approach based on those four features. The hybrid algorithm was introduced back in 2012, and essentially was trying to draw a roadmap for CTO PCI, which is more or less standardized in an algorithmic fashion that ensures both which ensures both a higher success rate, safe performance of the procedure, and equally important, quick and efficient use of the different approaches and different techniques. So we move from one strategy to the other, obviously trying to select the most appropriate initial strategy, but also the algorithm emphasizes the need to move from one strategy to the other, rather than getting stuck for 20 minutes doing the same thing and expecting a different outcome. So how do we look, or how do we incorporate those four features in our strategy? If the vessel has a clear, or the CTO has a clear proximal cap and the distal vessel is good, then an antegrade approach seems like the appropriate thing. If the lesion length is quite good, is quite long, that is more than 20 millimeters, or the course of the vessel is poorly understood, then your chances of being able to traverse the entire CTO segment going through to through becomes quite low, and an antegrade dissection re-entry strategy becomes the initial strategy of choice. If the lesion length is shortish and the vessel course is understood, a wire escalation going through for through is a reasonable approach. On the other hand, if the proximal cap is unclear and the distal vessel is severely diseased, then the retrograde route becomes the route of choice. In the presence of interventional collaterals, you would go for retrograde, obviously, and wire escalation versus dissection re-entry, which is reverse cut on this occasion, is again related to the lesion length and the clarity of the course of the CTO segment. However, if there is no interventional collateral, then the retrograde route is not really an option. So a quick example, again, a diseased mid-LED, totally occluded right coronary artery, very good and abundant septal perforators. And this is how you would want to evaluate them, looking at the septum from the side. So an RO cranial view is the best view to evaluate the takeoff of those septal perforators from the LED. And to better understand the lesion itself, you look at an LO cranial view, and now you can understand that this is an ambiguous proximal cap because it comes at the origin of a side branch. The lesion length is slightly over 25 millimeters, good distal vessel, good interventional collaterals, which are septal, and there's no calcifications or sharp bends really. So the plan was fix the LED first, try not to cover the second septal, although we can still go through septal branches through the stent struts. A brief antegrade trial. If that doesn't work, a retrograde strategy, going for wire escalation initially. And if we end up in the subintimal space with retrograde wire, we would go for a dissection re-entry or reverse cut. Mid-LED stented, going through the septals, as expected, wasn't an issue. We have the micro catheter now. It was easy going true to true, again, because there was no angulation really, and this is the final result. So the evaluation and the planning phase based on a proper angiogram with dual injection is fundamental. But it's also important to understand that this is not an ad hoc procedure. So we don't just do the diagnostic and jump into doing the PCI. We need time to review the angiogram, preferably with the whole team. And we do spend 15 to 20 minutes, and you'll be amazed how much more details you gather the more you look at that angiogram. Then we determine strategy. Determining complexity is fundamental because you really need to establish your chances of success and the risk-benefit ratio, and perhaps whether you are the most appropriate person for that job. So in JCTO scores of 4 and 5, where the lesion is very complex, or perhaps a very sick patient with a severely impaired ejection fraction, obviously would not be the best person or the best patient to try to treat early in your CTO experience. And determine access options, which can be bilateral radial, radial femoral, bilateral femoral, or occasionally, especially in post-bypass patients, triple access. And identify challenges and risks that are peculiar to this particular patient given his or her clinical circumstances and anatomical considerations. The third key component is the use of a micro catheter. And we used to say micro catheter or an over-the-wire balloon. And we now understand that using a micro catheter allows for establishing the base of operations. And one of the very quick things you can determine whether this person is someone who has not really been trained for CTO PCI is seeing someone who's handling a Gaia second or a Pilot 200 without the micro catheter. So these are fundamental components which show that you really know how this should be done, but also increase your success rates dramatically. So the combination of a dual injection, having two guiding catheters sitting in both sides, and using a micro catheter will substantially enhance your success rates without much else to learn, in all honesty. So the micro catheter allows for establishing a base of operations through which you can change different wires, change different wire curve shapes. It gives you better control of the wire tip because it removes any resistance encountered on the body of the wire in the proximal part of the vessel. It enhances support and wire pushability, and you can see how a Conquest Pro 12 or a BMW would behave with exponential increase in support the closer the tip is to the microcatheter. It will allow for wire exchange at different stages, which is something you will require. Obviously, you can't do retrograde without a microcatheter. It can allow for tip injection, which is important either for determining anatomy or resolving course ambiguity, or occasionally for deliberately doing contrast-induced microdissections. And we now understand that the use of an over-the-wire balloon is not synonymous. Because they're stiffer, they're more likely to kink, and the distal marker is usually placed at the middle of the balloon, so it doesn't really show you where the tip of the wire is, and you lose focus, or you lose understanding of where you really want to position the base of operations. Perhaps one of the fundamental things or the key components is understanding that it really takes all four strategies for a reasonably high success rate with CTO PCI. So you want to grade your anti-grade wiring skills, which is our bread and butter almost in every PCI, but mastering anti-grade decision re-entry, the retrograde approach, they're all complementary and necessary in securing a high success rate. While the anti-grade wiring is most commonly used as the initial strategy, retrograde and ADR are often required for more complex CTOs, and in such scenarios, they are not infrequently used as the primary approach. And the reason is we now know that the more complex anatomy you're dealing with in terms of lesion length, burden of calcification, tortuosity, bluntness of a proximal cap, and the presence of a prior failure, which are the 5 components of the JCTO score, the more unlikely that your anti-grade wire escalation techniques would work. And you will have to rely progressively as you increase with the complexity on dissection and re-entry therapies, whether they are anti-grade or retrograde. And we again know this from Progress CTO registry. This is looking at 6,000 CTO segments, CTO lesions, sorry. And you can see that as you move towards JCTO score 4 and 5, the antegrade wire escalation success rate falls below 20%, and the retrograde approach and ADR, or antegrade dissection reentry, become by far the dominant successful strategies. Now, again, another fundamental or key concept to keep in mind is the efficiency and flexibility that comes when we're dealing with CTOs. So if the initially selected crossing strategy fails, changing to an alternative technique increases the likelihood of success, shortens procedure time, lowers radiation and contrast use, and leads to an overall more effective and less frustrating program. And again, this is from an early analysis from the Progress CTO. And you can see that the initial strategy, regardless of what it is, whether it was antegrade wire escalation, ADR, or retrograde, was only successful in less than 50 or almost 50% of cases. And frequently, you would use a second, third, and fourth strategy. But being able to move seamlessly between all four eventually resulted in a success rate that is over 85% and an overall technical success of 87%. The one thing we stress again on this white paper is that these procedures obviously need the skill in terms of expertise and volume. And obviously, they need to be done within a special setup that secures specialized equipment, because such equipment will not only increase the likelihood of success, but will also facilitate the management of complications such as perforation or otherwise. So it is fundamental to understand that doing a CTO case does not equal having a CTO program. Similarly, doing a complex and high-risk indicated patient or CHIP does not equal to having a CHIP program. And what we really want to achieve is having a successful program that ensures consistent success and safety for all patients, rather than have the occasional successful case. And we know this data from the NCDR registry. And the NCDR registry looked at non-CTO centers, and this was back in 2013. And the overall success rates was 59%. And 59% is slightly higher than the chances of a flip of a coin. So the idea that you can achieve success, absolutely yes. But the whole point is, can you do that in a systematic fashion and secure success, or a very high chances of success each and every time? So the questions that you really want to ask yourself as a CTO operator to be is, are you passionate? Are you mentally flexible? Are you persistent? And that does not necessarily mean patient. And really, are you willing to fail and learn from failure? Because you will almost certainly be failing much more than your colleagues that are not doing CTOs. And if the answer is yes to all the above, this is what the real world data that we're getting, either from the Bureau CTO registry, from the Recharge registry, UK Open CTO registry, or Progress CTO, with success rates of 85 to 91%. And with an overall major adverse cardiovascular event rate that is 3%. And this was back in 2018. The recent unpublished data from Progress CTO is the overall MACE rate has fallen to 1.8%. And this is what I was mentioning earlier with the NCDR is a 59% procedural success rate in non-CTO PCR, non-CTO dedicated or specialized centers. So you can see the contrast between a dedicated program and non-dedicated program. And the only way to do this is really training and continuous education. So you have to be willing to go through a training and proctorship phase that takes you from mastering the antegrade wire escalation techniques, and as you progress with complexity, start to master antegrade dissection reentry, then go to retrograde via safe collaterals, which are septal collaterals and bypass grafts, and finally reach a stage where you can go through the more risky epicardial collaterals. And we actually have data to support that going through an initial training or proctorship phase, which was between 3 and 6 months on this paper, leads to a substantial increase in your success rate, especially with the more complex procedures requiring either ADR or retrograde approaches. So this is obviously a continuous process with exchange of expertise, meetings, workshops, seminars, webinars nowadays, but this is a very dynamic and active community with a lot of people who are willing, both in different regions of the world, to step in and help out. We are lucky to be in an era where self-education is really at the tips of our fingers. So reading, ebooks, and online platforms are invaluable in terms of being extremely useful sources of information. And these are just a few examples of what you can see in terms of online books and YouTube channels and different communities that really address the entire spectrum of CTO PCI. What would you expect? What you want to achieve is go safely through this initial phase where your experience really is close to nil, but with an alarmingly high confidence rate. And that will drop substantially as you gain more experience and will rise to more reasonable and realistic levels once you've reached the sort of maturity with an experienced operator. And again, this is from the NCDR database, and you can see that there is direct correlation between procedural success and your annual CTO volume, and the same applies to complication rates. And as an intricate part of continuous learning is continuous audit and improving outcomes. And we know that this is a fundamental component of any program. It's really the only way we can judge whether we're going in the right way or the wrong way, and what exactly are the key weaknesses that we need to work on. And one way to do that in a very didactic and structured fashion is to be able to join an international registry where you can benchmark against different centers, both that are at a more advanced or a more with more experience or with more volume, and try to look at the benchmarks, and this can be extremely useful in addressing key weaknesses in your practice. Now, one last thing is you've really gone through a very tenuous and tedious procedure, spent 3 hours trying to open an occluded vessel that has been occluded for 10 years, and you're happy about the result. The last thing you really want to do is have this patient come back with a totally occluded stent, or rather 3 or 4 stents 6 months down the line. So meticulous attention to lesion preparation and stenting techniques is fundamental, because ideally we want those patients to benefit acutely and to continue to benefit in the long term. And one key word besides regular PCI or good practice for PCI on the whole, but if I would leave you with one thing at this point, is aggressive use of intracoronary imaging. And with IVUS, we have sort of endless data now to support that the use of IVUS in complex anatomies, and this is in CTOs in particular, is associated with better outcomes at a relatively short follow-up interval. You can see how early those two curves diverge. Now, we've seen this with overall mortality. We've seen this with composite endpoints of cardiac death and myocardial infarction, and with target region revascularization. More recently, this is retrospective analysis of 10,000 patients from a single unit. And you can see that IVUS-guided versus angiography-guided PCI in complex anatomies, and these included CTOs, very long segments with more than 40 millimeters of stenting, or highly calcified lesions, or distal left mains requiring 2 stents. You can see how both curves diverge, both in terms of cardiac death and ischemia-driven TLR, that's clinically driven TLR, and with minor difference when it comes to stent thrombosis. So what exactly are the rewards after going through all of this? Is the ability to serve more deserving patients. One added benefit is the skill set one learns with CTO PCI is able to enhance your overall technical skills and overall competence way beyond CTO. So you will tackle bifurcations, you will encounter calcified lesions, extremely tortuous vessels, patients who need mechanical circulatory support. So the skill set that you acquire during this journey, I think pays off in other anatomies way beyond CTOs. And in fact, this is one of our papers from the group where the management of a huge LED and RCA aneurysm was only managed, we were only able to do so via a retrograde approach with very poorly developed collaterals in all honesty. And there are obviously team and institutional gains with the visibility that comes to institution, expanding programs, grants, being parts of registries and trials. But I can definitely tell you that boosting your ego is not one of the rewards. You will be put down, you will be frustrated, you will fail. So that's not really the reason to go into CTO PCI, and generating income, at least in the early years, is not going to be one of the rewards you could expect to see. But what we want to emphasize, perhaps as a last point, is this falls under a bigger umbrella of building a CHIP program. So when we start building a PCI program as a center or perhaps on a regional level, you really want your fellows to master physiological assessment, know their basic wire and balloon and stents, perhaps using 2 wires for bifurcation lesions, start to deal with longer lesions and slightly difficult anatomies that might require a guide extension, then go to left main PCI, perhaps multi-vessel PCI, then start to tackle calcified vessels with rotational atherectomy or laser or whatever. Then the last thing or the last bit on the top would be CTO PCI and LV assist, perhaps with TAVIs as well, or post-TAVI PCI. But it doesn't really make sense to establish a CTO program in a center that is poorly equipped to deal with the above, with the absence of imaging or rotational atherectomy or so forth. So this really comes on top of a big and solid program that can deal with very complex anatomies and patients. And the last thing is we've been able to gather a lot of information in CTO PCI on the whole, but we all know that that alone is not enough. We really need to be able to tie those bits and pieces and to develop networks and understand how this information can be put into a platform that really makes sense and aids with decision making. But again, wisdom comes in when you're able to cut the clutter and identify the 1 or 2 key areas in this particular patient or in this particular scenario. And this is sort of an everlasting endeavor to gather more knowledge, skill, and experience, and ultimately hope that this will transcend into better judgment, which is absolutely what you want to have and what you want to continue to improve whenever we're dealing with very sick patients, and being able again to identify which patient can benefit and what exactly is the risk-benefit ratio in this particular scenario. Thank you so much.
Thank you, Ahmed. Actually, this is one of the best lectures I ever heard regarding chronic total occlusion.
Thank you.
Definitely.
You're being very kind as well.
No, this is very true. Actually, you combined guidelines with skills and techniques and wisdom and knowledge. Congratulations, Ahmed. Very, very, very lovely presentation. احنا ممكن نفتح for few minutes المجال لسؤال او 2 وخليني ابدا. لو انا عندي عيان عنده heart failure with reduced ejection fraction, ischemic cardiomyopathy, I have no evidence for active ischemia, but he has CTO left anterior descending. سؤالي, is this patient going to benefit from opening his CTO left anterior descending regarding left ventricular function in the absence of subjective and objective evidence of significant ischemia? رأيك إيه أحمد؟
And symptoms that are purely heart failure.
Yes, progressive heart failure.
The answer, Dr. Mohammed, is we don't have evidence for that. So the Explore trial looked particularly at this point, and it was a negative study. There are flaws with the design, but so far it is difficult to discern that those patients will benefit from a single vessel PCI. On the other hand, if this were a multi-vessel disease, or perhaps proximal LED and proximal circumflex disease, 2-vessel disease, or 3-vessel disease with severely impaired ejection fraction and viability rather than reversible ischemia as such, we know if we extrapolate data from the STITCH study that those patients can derive benefit, not particularly in terms of ventricular function, but in terms of survival. So it is an area where, again, there is a lot of judgment that goes on individual levels, but I would be cautious trying to fix and we actually just had the patient today discussed in our JCC with an ejection fraction of 15% and only proximal LED CTO. And very subendocardial late gadolinium enhancement only on CMR. And the collective decision is both us and our surgical colleagues were very unhappy about the chances of this ventricular function improving with fixing the LED with a totally normal circumflex on right. It just doesn't add up in terms of the burden of ischemia, does not translate into how bad the ventricular function is. So again, in the absence of data, we need either a clearer clinical picture or perhaps more evidence of widespread ischemia, even if it were circumstantial evidence.
Yes, this is true because sometimes it's difficult to search for viability. We don't have a perfect tool for viability, and you have nothing to do for this patient unless trying to stop the remodeling process, especially if he's early, not so late in heart failure progress. Thank you. Now, do we have questions for Professor Ahmed Al-Gindi?
وأنا كنت expect question بتاع حضرتك يا دكتور محمد about the possibility إن إحنا نعمل interventions لما يكونش في definite evidence of ischemia in these patients. أنا عارف إن في studies ورت إن patients improve, بس overall practically, can you really revascularize a patient who has no positive ischemic يعني objectives موجودة?
Yes, if my patient has a reduced ejection fraction and multi-vessel disease, LAD, CX, right coronary artery, definitely I would go for a revascularization trying to save his myocardium. This is what Dr. Ahmed Al-Gindi.
Multi-vessel disease, Dr. Muhammad, in general, objective evidence of ischemia with different non-invasive techniques ما تبقاش very accurate. يعني nothing shows the absolute ischemia. بس بتكلم بقى لو كان one vessel. وده معظم
I think with one vessel, Dr. Yasser, you need to either have symptoms or establish that there is a large burden of ischemia. Now we're questioning now what really a large burden of ischemia in the absence of symptoms means in the light of the results of the ischemia trial. But at least before ischemia, this is the rationale we had in mind. So you either have symptoms or in the absence of symptoms, you have a large burden of ischemia. Now, the important thing that perhaps the caveat is with CTOs in particular, those patients, almost 40 to 50%, report a very abnormal pattern of symptoms compared to patients with subocclusive disease. And this is mostly poor exercise tolerance. And it seems that they have somehow conditioned their myocardium to chronic ischemia, and angina does not become the predominant complaint, but rather poor exercise tolerance by essentially that they have accustomed their exercise levels to a lower level to deal with chronic ischemia. So it's important that the history taking is done in a very sort of exploratory fashion that digs deep beyond angina. بالتالي دكتور محمد النتورك عندي او النتورك عندي انا بقت وحشه.
اسالك سؤال تاني يا احمد، البيشنت اللي انت عملته اللي هو كان 54 سنه ده، how much did the procedure cost تقريبا البيشنت ده؟
I think this is close to 300,000.
300.
Yes.
And he refused surgery اصلا من الاول؟
It was a post-cabbage patient, so redo with a LED and 3 grafts. I don't think that redo cabbage is really something we resort to nowadays, unless in very, very peculiar circumstances when there's perhaps concomitant mitral valve disease. But a redo cabbage is becoming progressively infrequent.
دكتور هشام هتتكلم؟ عايز ارحب بالدكتور هشام صلاح زميلنا، استاذ الدكتور هشام صلاح معانا انضم لينا من فتره. دكتور هشام مساء الخير. تمام، يبدو ان الدكتور هشام مش سامعني.
لا دكتور هشام سامعك. ازيك يا دكتور محمد، عامل ايه؟
من زمان نفسي اسمع صوتك.
ايه الاخبار، عامل ايه؟ كويس؟
الحمد لله.
طبعا احيي المجموعه كلها. انا لسه داخل دلوقتي معاكم وللاسف مش هقعد كتير، فيا دوبك ما سمعتش ولا كلمه. سمعت حاجه 3 فيسل ومش عارف ايه، حاجات كده بسيطه.
لا انا عايز اقول لك الدكتور احمد الجندي ادانا محاضره CTO ممتازه، انا فعلا ما سمعتش زيها في اي مكان. يعني غالبا هسجلها لك وابعتها لك.
احمد يعني من الناس اللي
وحشنا يا دكتور هشام، افتقدناك.
الله يخليك الله يخليك. انا يعني طبعا انا سعيد ان انا معاكم. انا دلوقتي سايق بس للاسف مش هعرف اطول معاكم. انا قاعد معاكم 5 دقائق ولا حاجه، عايز استمتع بالكلام. الحقيقه انا I'm very interested as well to know الشباب بتوعنا اللي عندكم اخبارهم ايه وماشيين ازاي. فالحقيقه كنت داخل اسمع برضه طبعا احمد اكيد، وفي نفس الوقت اسمع احمد امين وايريني وكده، لان انا I'm really very interested to check that their progress is going fine. احنا بنشوف احيانا الناس بيطلعوا، لسه كان حد بس مش عايز اتكلم يعني، بنسافر بره مصر والحقيقه المستوى لقيته مش حلو. بس طبعا this is not the situation في
اسوان. بس دكتور هشام الله حليم ستار. ما تخليش ال5 دقائق اللي هتقعدهم يبقوا فيهم.
اهلا
بيك يا وليد. اكيد. ازيك يا وليد، عامل ايه؟
اهلا بيكم. دكتور احمد, would you please introduce our next speaker?
بس حضرتك تنقي إيريني ولا أحمد؟ تحب مين الأول؟
أنا في الأجندة اللي عندي إيريني صامويل هي اللي عليها الدور.
إيريني انضمت لينا السنة اللي فاتت، وطبعا أنا مش هعرفها الاسم في اسمها، بس كان واحدة من الناس that we are happy to have amongst the squad. وهي النهارده هتتكلم perhaps that this is not related to her thesis directly, but it is a program that she has been involved in, which is pulmonary arterial hypertension, and she's mostly going to focus on patients with advanced PAH.
Hello.
تفضلي يا إيرين.
Thank you, Dr. Mohammed. Thank you, Dr. Ahmed. It's my pleasure to be part of this webinar today. We're going to talk about the management of patients with advanced pulmonary arterial hypertension. We'll start with the definition of the pulmonary arterial hypertension, which includes 3 hemodynamic parameters as measured by the right heart cath. The first one is having a mean pulmonary artery pressure more than 25 millimeter mercury. Actually, recently a new figure was proposed, which is 20 instead of 25. Based on observations that the cohort of people having a mean pulmonary pressure between 21 and 24, they are actually having a higher risk of progression of the PH on the long term and a higher risk of mortality than the normal population. But so far, there's no enough data to consider them having a pulmonary hypertension. So the recommendations came up just for close monitoring for those cohorts. In addition to the pressure, we should have a pulmonary artery wedge pressure less than 15 millimeter mercury and pulmonary vascular resistance more than 3 Woods. Pulmonary arterial hypertension is group 1 in the 5 groups classification. It includes various subtypes like the idiopathic, heritable, drug-induced, and those associated with connective tissue disease. The management of PAH consists of 3 steps. The first one is the diagnosis. That should be a proper and early diagnosis. Unfortunately, despite the greater awareness nowadays, but we still have a significant delay between the onset of the symptoms and the proper diagnosis of the patient and starting treatment. The second step is the risk stratification, and the third step is the therapy. We'll try to cover these 3 steps using a case-based approach. Our case is 21-year-old male. He's not known to be diabetic or hypertensive, presenting with progressive dyspnea, function class 2 to 3. He's complaining of occasional attacks of syncope on exertion. He has unremarkable past history. On clinical examination, he had signs of right-sided heart failure, and his 6-minute walk distance was 180 meters. Here is his echocardiography showing a markedly and impaired right ventricle with flattening of interventricular septum and pericardial effusion, and significant tricuspid regurg with tricuspid regurg Vmax around 5 meters per second. By checking the diagnostic algorithm of the PH, we should do different investigations to exclude other causes of pulmonary hypertension, like high resolution CT chest to exclude parenchymal lung diseases, VQ scan to exclude CTEPH, and TE to exclude congenital heart disease, ending up with the right heart cath, which is the core for the definitive diagnosis of pulmonary hypertension, and also it helps in quantification of the severity of the disease. So his right heart cath results showed a mean pulmonary artery pressure 75 millimeter mercury, which remained unchanged even after performing acute vasoreactivity test, with LV-DETP 8 millimeter mercury and cardiac index 2. Now the next step is risk stratification. This table is showing a multi-parametric clinical, functional, exercise, and biochemical, imaging, and hemodynamics variables that helps classification our patients into 3 categories, which accordingly can determine their prognostic. These variables have a prognostic significance in addition to helping in the decision of the therapy. For our patient, most of his criteria lies in the intermediate to high risk. Next step is the therapy. Actually, whenever starting treatment for PAH patient, we should always keep in mind that achieving a low risk status for our patients is the main target of the therapy, helping them to have a better functional and exercise capacity and a lower mortality risk. السلايد دي is showing the 3 abnormal pathways involved in the pathogenesis of PH. It includes the nitric oxide and the prostaglandin pathways, which is usually underexpressed in the PH patients, where endothelin pathway, which is usually overexpressed in the PH patients. Actually, the imbalance between the vasoactive mediators is responsible for the development and the progression of the proliferation and the obstruction of the distal pulmonary arteries, ending up with severe pulmonary hypertension and right-sided heart failure and eventually death. The table that is showing the currently so far approved medication for the treatment of PH. We'll focus أكتر على drugs available عندنا. The first group is the phosphodiesterase 5 inhibitors, which includes the sildenafil and tadalafil. Both are more or less available and affordable. Tadalafil, in addition of approving its significance as a monotherapy, it shared in 2 big combination trials. واحدة منهم كانت مع الأمبريسرتان، واحدة منهم كانت مع الماسيتانتان. The second group is the endothelin receptor antagonist, which includes أول واحد في الجروب ده bosentan, which is its dose is 125 milligram twice per day. In addition to its role in idiopathic PH patients, it's highly indicated in the patients with Eisenmenger syndrome. One of its well-known side effects is the liver toxicity. So it needs a monthly follow-up of liver function tests while using it. تاني واحد في الجروب ده is the ambrisertan. Its dose is 5 to 10 milligram once per day. The latest one to be approved in this group is the macitentan, which actually has a very good pharmacokinetics and dynamics in comparison with the bosentan and ambrisentan, it has a sustained receptor binding and enhanced tissue penetration. One more thing, no liver toxicity was reported with it خالص. The only side effects reported with it was the anemia, but it occurred in just 4% of the patients. Next is the selcipag, which is oral available prostacyclin receptor agonists. It showed a good benefit as an add-on therapy for the intermediate risk patients. بعد كده الرايسجويت, which in addition to its role in the PAH patient, it has a class 1 indication for inoperable CTEPH patients or those with residual pulmonary hypertension even after endarterectomy. The last one is the treprostinil. We will talk about it in details later on in the presentation. Now comes an important question. Should initial combination therapy be the standard of care in PAH patients? Actually, combination therapy is not a new concept, but what's well known is the sequential combination, either in the PH or other chronic diseases. And now we usually start with one drug, following up the response, if inadequate, adding on another one, and so on. Today, we need to settle down the concept of the upfront combination, which is initiation of the combination therapy immediately at the time of diagnosis. A rationale of the upfront combination therapy, having a rapidly progressive disease with high mortality, so we should be more aggressive to gain a more maximum control of the disease. تاني حاجة, as we have just mentioned, إنه our main target is achieving a low risk status, which is actually not that much easy in real world, يعني, especially in those patients with advanced disease. Third point is that we have different pathways involved in the pathogenesis, as we have just showed. We know single pathway plays a dominant pathogenic role, so trying to targeting multiple pathways simultaneously will have the benefit of synergistic effects. آخر حاجة إنه what's so-called mild disease is actually it's not an early disease. في study اتعملت assessing the efficacy of bosentan on patients with functional class 2. At the time of enrollment, despite all the patients have mild symptoms, but their hemodynamics showed a mean pulmonary artery pressure more than 52 and PVR more than 8 Woods. So actually, they are having advanced disease. This is not an early disease. The Ambition trial, it was a landmark study that was published in 2015. It was the first study to assess initial oral combination therapy versus initial monotherapy in naive PAH patients. And its results showed a 50% lower risk of developing primary endpoint in those who received the initial combination therapy versus those who received monotherapy. So accordingly came up the recommendations for treatment of naive PAH patients with function class 2 to 3. We recommend initial combination therapy. Right, back to our patient. To wrap up, he was diagnosed to have idiopathic PAH with more or less high risk category. So he was started on oral combination therapy to be reassessed after 3 months. His follow-up after 3 months, unfortunately, showed a worsening of his dyspnea and more frequent attacks of syncope, highly elevated pro-BNP, and we was already on double oral combination therapy, sildenafil and bosentan, in addition to diuretics and oral anticoagulation, and the patient started to develop atrial arrhythmia. His follow-up right heart cath showed a cardiac index of 1.8. So there was a deteriorating hemodynamic parameters despite the combination therapy. And all his criteria moved to the high risk category. The American College of Chest Physicians recommends in the patients with functional class 3 with evidence of rapid disease progression, it's recommended to start a parenteral prostanoid, either IV epiprostanol or IV or subcutaneous treprostinil. Epiprostanol is the first drug approved for the treatment of PH in the mid-90s, where it showed improvement in the symptoms of exercise capacity or hemodynamics, which so far the only PH medication that demonstrate a mortality benefit in a prospective randomized trial. But actually, despite these favorable outcomes, it's not an ideal treatment because of its, it is chemically unstable with very short plasma half-life, and it can be administered only as a continuous intravenous infusion. So there is a risk of serious side effects like sepsis, catheter thrombosis, or due to its very short half-life, abrupt interruption of the infusion leading to a significant hemodynamic deterioration. Treprostinil is a prostacyclin analog with similar properties to epiprostanol, with the privilege of being chemically stable with a longer half-life, and it can be administered by continuous subcutaneous infusion. Continuous subcutaneous infusion is the preferred mode. It is initiated at a dose of 1.25 nanogram per kg per minute and gradually up-titrated by 1.25 to 2.5 nanogram per week. Our target dose is the dose keeping the PH symptoms minimal while minimizing the excessive side effects, which is usually around 40 nanogram per kg per minute. This is the picture of the infusion set, just to be familiar with it. A micro infusion pump, usually the syringe is filled with the drug and placed in a cartridge in the micro infusion pump, then connected to a thread-like catheter to one end, and the other end is connected to the skin. Infusion site pain and reaction is the most common complication of the subcutaneous treprostinil. It occurred in around 85% of the patient, but in most of the time, it's transient and benign. We usually, just symptomatic treatment or local treatment leads to its improvement. PH is a rapidly progressive disease with very high mortality. The median survival in the patients without treatment is around 2.8 years. As we previously said, epiprostanol is the only drug so far that demonstrated a reduced mortality based on a single prospective randomized control trial, but actually treprostinil is now showing a promising survival benefit. في الجراف ده the dashed line is showing the expected survival rates of the PH patients without treatment. The dotted line showing the survival rates with the IV epiprostanol, and the continuous line is showing the survival rates observed with subcutaneous treprostinil. So actually, the observed survival rates with subcutaneous treprostinil were higher than the expected survivors and very comparable to those observed with the IV epiprostanil. Okay, next I would like to talk about the pulmonary hypertension program at Aswan Heart Center, which is one of the very important programs we have. It's composed of a well-trained PH team of physicians and specialized nurses. We're offering service in addition to Aswan Heart Center. We have a special PH clinic in Cairo. Our service includes a clinical aspect and research aspect. For the clinical aspect, in addition to the basic diagnostic workup, the basic clinical assessment and imaging for all the patients. All the patients usually have a significant, an objective assessment of exercise capacity. كل البيشنتس بيعملوا a baseline 6-minute walk distance at the baseline and every time at the follow-up to see their progress and the response to the medications. For all patients, we do B&B, which has a very important prognostic significance. CMR to properly assess the RV volumes and function. And in the right heart cath, in addition to the basic hemodynamics, vascular activity test is performed for those who are indicated, and pulmonary angiography for the CTEPH patient. Regarding the disease target therapies, we're supplying monthly Bozentane for a group of patients who cannot afford it. وفي patients بنبعت لهم ماسيتانتان. البيشنتس اللي هم who cannot tolerate liver toxicity of the Bozentane at all. We have other group of patients, important group, which are on subcutaneous treprostinil. Actually, patients دول, whenever they are candidates for the subcutaneous treprostinil, بيتعمل لهم counseling كويس قوي about the drug and expected benefits, expected side effects of the drug. وبعد كده, whenever we are planning to insert it, بيبقوا admitted in hospital for around 5 days to observe them closely in the first days. Where actually our specialized nurses plays an important role in their education and the training of the patient, how they will deal with the infusion, how they will deal with the side pain, بيتأكدوا إن هم بيعرفوا يحطوا البامب لنفسهم كويس ويتعاملوا معاها كويس قوي. There is on-call calls available 24/7 for this group of patients. At any time حصل أي حاجة بيكلمونا, حد بيرد عليهم على طول. تاني حاجة في disease target therapy, pulmonary end artectomy, which is actually potentially curative surgery for CTEPH patients. The last step in the clinical aspect, the long-term follow-up to assess the response to treatment for every patient. Regarding the research aspect, in addition to having a detailed database, we are sharing in the Egyptian Collaborative Registry with the Military Academy. So far in this registry, we have 260 total patients, 62% of them having idiopathic pulmonary arterial hypertension, and 27% of them having CTEPH. Also, meanwhile, we have an ongoing clinical trial which assess the effect of treprostinil on right ventricular structure and function in patients with pulmonary arterial hypertension. Now we'll show كده examples of the patients on subcutaneous treprostinil. This is a 36-year-old female presenting with function class 3 to 4 with frequent syncope and manifestations of right-sided heart failure with 6-minute walk distance 60 meters and highly elevated pro-BNP. She's already on combined oral therapy in addition to diuretics. Her right atrial pressure is 17 millimeter mercury, and her mean pulmonary pressure is 70, cardiac index 1.6. Subcutaneous treprostinil infusion was initiated in this patient, and her follow-up after 12 months showed improved functional class with no syncope, marked improvement in the 6-minute walk distance and the pro-BNP. This echo is showing the baseline echo and the follow-up one after 12 months with marked improvement in the pressure overload, marked improvement in the RV volumes and function. Her CMR at baseline and follow-up showing a marked improvement in the RV volumes and function. A right atrial pressure dropped to 7 from 17, and her cardiac index increased to 2.4 from 1.6, almost normalized. Second patient is 23-year-old female, functional class 4 with frequent syncope and severe right side heart failure on combined oral therapy. Also, subcutaneous treprostinil infusion was initiated in this patient, and her follow-up showed a marked improvement in her functional class. There is no more syncope. Where this curve is showing a curve بتاع البرو بي ان بي at baseline and during her follow-up it almost normalized. The follow-up of the 6-month walk distance in comparison from the baseline up to the 12-month follow-up. Her MRI showed a little bit improvement in the RV volumes, but a significant improvement in the RV function. And her right heart cath showed a marked improvement in her cardiac index from 1.4 to 2.5. So our take-home message is that diagnosis and treatment of PAH must be as early as possible. And overall, our treatment goal is achieving a low-risk status. Upfront combination therapy is the best approach to treat newly diagnosed non-vascular active patients. Subcutaneous treprostinil is not the drug of first choice in all patients, but it may be a good option that improve outcome in advanced case. Thank you.
Thank you إيريني. الحقيقة أنت خليتيني يعني بحلم إن أنا يبقى عندي كمان في اسم القلب Pulmonary Hypertension Clinic مشابهة أو دوتر لل Pulmonary Hypertension Program اللي في أسوان هارت سنتر. والمناسبة يعني البرنامج بتاع النهارده كله أحلام. دكتور أحمد الجندي طبعا هو عارف إن هو ساعدنا في بداية الCTO بروجرام من كام شهر، وبعد كده جت الكورونا عطلتنا شوية. وكذلك البلمونري هايبرتنشن كلينيك احنا كنا بدأنا عيادة أو مشروع عيادة كده، لكن برضو جت عطلتنا. دكتور أحمد حسن كان هو المشروع مسؤول عن البلمونري هايبرتنشن عندنا. دكتور أحمد تقول كومنت.
السلام عليكم. زي ما حضرتك قلت بالظبط بدأنا عيادة PH قبل البانديميك يمكن بدأنا عيادتين. يعني اعتقد ان المشروع ان شاء الله هينجح وهيمشي، واحنا نعمل بالظبط زي حضرتك شفتوا في اسوان بروجكت. القصر العيني برضو فيه مميزات ان عندنا جميع التخصصات، ف يعني قد يكون هقدر افوكس كمان اكتر شويه على عينيك كونكتيف ديسيز وبعض الكونجنتال هارت ديزيز. برضو الايزنمنجر احنا بنشوفهم كتير جدا في اسم القلب. احنا بدأنا فعلا عملنا فيو رايت هارت كاست، ممكن يكون محتاجين لسه بعض الحاجات زي الفازور اكتيفيتي ايجنتس، لكن معظم السيت اب للبروجكت يعني ممكن يبقى بسيط باذن الله.
دكتور احمد الجندي، هل ممكن نعمل توأمة للبروجرام ده هو بحيث ان احنا العيان ممكن يستفيد منا ومنكم اللي مش قادر يسافر او اللي يقدر يسافر يعمل جزء هنا وجزء هنا؟ ايه رايك؟
طبعا يا دكتور محمد، في حاجه غير انها اوريدي قوام التيم نفس الصوره كانت يعني متاخده في وقت مش كل التيم موجود، انما سواء دكتور احمد او دكتور كريم are pillars of the program، وهم متواجدين بشكل يعني منتظم من ناحيتين. ف I think انه القابليه النيه موجوده، القابليه زي ما احمد قال I think it's pretty easy. وin terms of service هم عيانين بعضهم يعني they are in a very miserable shape، والسفر بالنسبه لهم حاجه متعبه، فبيتهيألي ان يعني اهم محرك للحكايه دي هتبقى لخدمه مرضى محتاجين. ف I see it as only a natural evolution صراحة، مش شايف حاجة تمنعها خالص.
تمام. هل في أي أسئلة للدكتورة إيريني؟ طيب نشكر الدكتورة إيريني ونهنيها، وأدي الميكروفون للدكتور أحمد الجندي يقدم لاست سبيكر دكتور أحمد أمين. اتفضل دكتور أحمد.
Thank you, Dr. Our last speaker for the night, we hope we haven't bored you ولا طولنا كتير. My colleague, Dr. Ahmed Amin. Ahmed is in charge of one of the people who are focused on the Gooch program for Aswan, and he's mostly working with the pediatric team, although جزء من the pediatric team is currently running the Gooch service, given their familiarity with congenital heart diseases on the whole. إنما من سنة ونص we decided to establish a nascent but definitely a separate unit for Gooch on the whole, to address those patients as they grow up, which I'm sure all of you know that they somehow present with very peculiar problems and complications, and they require the follow-up, the counseling, and dealing with quite complex congenital heart disease at an old age, which is an area أنا نفسي يعني حاسس إنه we all are deficient فيها، إنما definitely هي deficient في مصر ككل. فأحمد will address congenitally corrected transposition of the great arteries. Ahmed.
Assalamu alaikum. I'm glad to be in front of all my professors and colleagues today to present. My topic is about congenitally corrected TGA in Gooch clinic and the grown-up congenital heart disease clinic. CCTGA, or the other name double discordance, as the name implies, it shows a two-level of discordance at the level of the atrioventricular and ventriculo-arterial level. So on the photo on the left side showing normally arranged atrium, in which the morphologically right atrium on the right side connected to the morphological left ventricle, which is connected to the pulmonary artery. And on the other hand, the left morphologically left atrium is connected to the morphological right ventricle, giving rise to the aorta. The picture on the right side showing what we say as a mirror image orientation of the atria, in which the morphologically left atrium on the right side and the morphologic right atrium on the left side, and the reverse occurs. Actually, the more common variable of the congenitally corrected TGA is on the left side, and rarely we see the mirror image orientation of the atrium. In the normal heart, we see the circulatory pathways are in series, in which the systemic blood goes to the right side of the heart and then to the lungs and then back to the left ventricle and go to the systemic blood vessels. So the circulation in series. However, in transposition of the great arteries, as we have only discordance at the level of the ventriculo-arterial side, we do see that the systemic blood goes to the right side and then back to the aorta, to the systemic circulation. And on the left side, the pulmonary blood coming to the left ventricle, going back into the pulmonary artery. And these circulatory pathways are in parallel. And this is incompatible with life unless there is some sort of mixing at the level of the atrium, the ventricles, or the great vessels like ASD or VSD or BDA. In the congenitally corrected TGA, we have only anatomic abnormality. However, physiologically, there's still the circulation is running in series, as at the end, the blood coming from the systemic veins go to the lung to be oxygenated, and the pulmonary blood coming to the right side of the heart going to the systemic circulation, and it is oxygenated. So it is physiologically congenitally corrected TGA. Baron Rokitansky is one who, he's someone who studied heart pathology in the 1800s. And he's the one who was first described in his atlas. This image is from his atlas, and it shows that the morphologically right ventricle on the left side giving rise to the anteriorly displaced aorta, and the morphologic left ventricle on the right side giving rise to the posteriorly displaced pulmonary artery. It's like a cross section. So he described it in his famous atlas of heart pathology. The basic embryology for such anomaly usually is a heart tube. It rotates to the right with dextrolooping, in which the part that gives rise to the right ventricle, which is the bulbous cordis, is on the right side, and the primitive ventricle gives rise to the left ventricle. However, in CCTGA, usually it has the heart tube rotates to the left side, causing L-looping, causing the bulbous cordis to be on the left side, making this the right ventricle to be on the left side and the left ventricle to be on the right side. The basic morphology, the atria, as we already mentioned, the usual arrangement versus mirror image, which is very, very rare, but we never have isomer atria. Isomer atria is both are morphologically right or both are morphologically left. So this never happens in CCTGA. The AV connection discordant, the VA connection is discordant. The great arteries relationship are variable, and we will see it in a minute in illustrative photo. And the orientation of the heart is usually variable. It may be dextro in dextro position, in levo position. It may be mesocardial, in which the apex is directly behind the sternum in 20% of the cases. And this will have a clinical implication, as we'll mention later. And the coronaries arise according to the topology of the ventricle, whether the right ventricle on the right side or on the left, as we will show later. Here is a picture of, it's like a CT heart and with the coronaries, where you see the patient from his foot. And as we know, usually the pulmonary artery is in the normal situs, is anterior and to the left. And the aorta is posterior and to the right. In TGA, the aorta is usually anterior and to the right to the pulmonary artery. However, in congenitally corrected TGA, the aorta is usually on the left side and anterior to the pulmonary artery. And hence some say the term LTGA as a synonymous for CCTGA, but this is not a right term to use, because in usual arrangement of the atria, the aorta is anterior and to the left. However, in mirror image atria, the aorta comes to be more anterior and to the right. So you cannot use LTGA for CCTGA. You have to describe what you see. Sometimes they come side by side. The ventricular topology, usually the normal ventricular topology is right-handed. And this means when you put the palmar surface on the septum of the right ventricle, and the thumb goes in the inlet, however, the fingers go in the outlet, usually because the right ventricle is on the right side, so normally ventricles are of right-hand topology. However, in CCTGA, it's of left-hand topology, since the right ventricle comes on the left side, unless, again, in mirror image atria, all is reversed back to normal. The key to many of the features and the clinical symptoms of those patients is septal malalignment. Septal malalignment is caused by, because of the pulmonary valve is insinuated between the mitral and the tricuspid valve, causing the atrial septum and the ventricular septum to be malaligned away from each other. And this causes important feature of the CCTGA, which is conduction abnormalities, AV block of all degrees, and sometimes it's progressive over time due to fibrosis. However, less septal malalignment occurs if there is severe pulmonary stenosis, pulmonary or subpulmonary or pulmonary atresia. And this is more common with mirror image atria, and therefore this rare type of CCTGA are less likely to develop conduction abnormalities. Almost rarely CCTGA comes with no anomalies. So any CCTGA, there should be associated anomalies. Very, very, very rarely to see those patients with no associated anomalies. The most common is ventricular septal defect. They come in all sites, but they are typically perimembranous with subpulmonary extension. And the second most common is LVOT obstruction, which gives rise to the pulmonary and subpulmonary and subpulmonary stenosis. And this is important for categorization and, of course, affects the clinical picture. And tricuspid valve anomalies, they are more than 90% of the patients in autopsies in small studies. For those patients that have tricuspid valve anomalies, they are variable. The most common is tricuspid valve dysplasia and epistenoid tricuspid valve. And morphological RV dysfunction occurs as a consequence, but it's not yet understood because tricuspid valve anomalies are not the only thing that explains this dysfunction, and it is of unpredictable behavior, sometimes presenting early, but sometimes they present late, and there are no governing factors, but there are precipitating factors. As regards the septal malalignment in the usual atrial arrangement, as we can see, this is the normal AV node. It's posteriorly situated at the apex of the triangle of Koch. And in this situation, because of the septal malalignment, it cannot connect with the AV bundle. And in those patients, they have accessory anterolateral node between the tricuspid valve and the pulmonary valve in this fibrosa, which it perforates it and connects after going a long way to the AV bundle. Some patients have both AV nodes and they are connected with a conduction sling, but mostly they have a normal or accessory anterolateral node. In the mirror image arrangement, usually because of the less septal malalignment, you usually have normal AV node and AV connection, and less common to have AV conduction anomalies. And here's another picture of the relation of the AV bundle, which runs beneath the pulmonary valve in supra-anterior relationship to the VSD, dividing into left bundle and right bundle. The causes of LVOT obstruction are variable. Tissue tags from the insinuated valves, sometimes fibrous shelves, sometimes muscular hypertrophy in the LVOT is variable degrees. Here we can see the tricuspid valve attachments are displaced downwards. However, in this case, we don't say that Epstein valve is usually epistenoid, as the right ventricle is usually not affected. It's of normal thickness and of normal volume. The coronary anatomy is variable according to the topology of the ventricle. So the right coronary system may give rise to the left anterior descending as a circumflex supplying the left ventricle, and the left coronary system give rise to the artery supplying the right ventricle. And here we don't name the sinuses as right and left coronary sinus. They take names after sinus 1 and sinus 2 by imagining the surgeon sitting in the non-facing sinus to the pulmonary valve. The sinus on the right hand is named sinus 1, and on the left hand is sinus 2. And this is better for describing the arising of coronary arteries and for preparation of surgery. The incidence of this of CCTGA is extremely rare. The male to female ratio 1.6. Clinical picture is variable because of the associated lesions and the unpredictable behavior, as we mentioned earlier, for the morphological right ventricle and the tricuspid regurg. With patients with no anomalies, no associated anomalies, which is extremely rare, those patients may pass unnoticed and they are discovered accidentally and they are totally asymptomatic. However, both patients, as we previously said, those who have pulmonary stenosis and those who have unobstructed pulmonary flow, if the unobstructed pulmonary flow, they present with VSD moderate or large, they present with heart failure, usually in the younger age groups, not presenting to our adult clinic. And if there's pulmonary stenosis, according to the severity, they present with variable degrees of cyanosis. However, in the adult group, or those who were not previously diagnosed, they may be first diagnosed by heart block, and it is progressive, as we mentioned. Some of the patients who are already diagnosed, they develop with time RV dysfunction and severe tricuspid regurgitation. In one study, almost 50% of the patients who reaching 30 years of age developed heart failure because of RV dysfunction. Or it may be a complication of a previous surgery that we will talk about later, in which they have a conduit dysfunction because they have outgrow this conduit between the right ventricle and the pulmonary artery. The investigation in the EKG, it's the key here is we have the septal activation, which is normally from the left to the right. We have now the right ventricle on the left side and the left ventricle on the right side, so the reverse actually happens. And therefore, we will have absent R waves on the right pericardial leads, and sometimes flat T waves on the left pericardial leads, and there is reversal of the QRS pattern in the pericardial leads than in the normal. Of course, this with variable degrees of heart block, and these all changes will be back to normal if, again, we have mirror image arrangement of the atria, because it makes the ventricles goes back to normal. In the chest X-ray, is not diagnostic. However, high suspicion when you see an X-ray for a patient with congenital heart disease and there is abnormal position of the heart, whether it's dextro position, the heart is more on the right side or on the left side, or is kind of in the middle as the mesocardia, the first suspicion should go in mind is CCTG. However, that's not diagnostic. And of course, those who have inserted a pacemaker in congenital heart disease usually think CCTGA. In the echo, we usually think segmental analysis. We start from the atria and venous drainage and pulmonary and systemic venous drainage, as in the sequence on the left side, we can see the morphologic right ventricle is on the left side with the moderator band right here, as in the picture, and displays the tricuspid valve, and the morphologic left ventricle on the right side with smooth surface on the right side. And here we can see a large perimembranous VSD. We should try to look for valve abnormalities. Sometimes they have a straddling tricuspid valve in which the leaflets have a septal, the tricuspid valve has septal attachment on the other side of the ventricle, not on the same side. And by anterior tilting, we'll first find the pulmonary artery with both branching, the RBA and the LPA, arising from the morphologic left ventricle. And more anterior tilting, the aorta starts to appear, arising from the morphologic right ventricle. And here, the aorta is anterior and to the left to the pulmonary artery, as we have seen in both pictures. We can also detect it from the subcostal views, in which the left ventricle is the anterior chamber, giving rise to pulmonary artery, and in short axis at the ventricular level, we'll see the morphologic right ventricle with the septal attachment of the tricuspid valve is on the left side, and the the left ventricle on the right side, and giving their great vessels which can be differentiated by the branching of the pulmonary artery or the arching of the aorta accordingly. And we can detect the complications like stenosis, and here is a tissue tag arising from the pulmonary valve causing subpulmonary stenosis. And as we previously mentioned, especially in the adult population, patient with mesocardia or abnormal heart position, sometimes they are difficulty to be diagnosed by echo, and we need more confirmation, more data, especially about the associated lesion involving the great vessels to be added by the CT. So the CT here comes handy. We also start by segmental analysis, starting from the draining of the atrium. This is the morphologic left atrium with a left atrial appendage characteristic with narrow-based appendage, giving rise to to this left-sided ventricle, which is of right ventricular morphology owing to the presence of this moderator band. And there's a lot of features, but this is just for simplification. And on the other hand, on the other hand, the right morphological right atrium giving rise to the left ventricle with a smooth surface septum. Of course, there is large perimembranous VSD. Now we see the ventricular arterial connection, and we can look for here the aorta is anterior and to the left, and it's arising from the morphologic right ventricle, and the pulmonary, which is arising from the morphologic left ventricle, giving rise to both pulmonary artery. And what is very evident in here. And there is both pulmonary, both stenotic pulmonary dilatation. So we can detect even the complication, and we can also look for the coronary artery morphology, as we previously said. This is the right coronary sinus, the sinus 2, but this is from the other side. It's not the surgeon view. So just for simplification, we can here also describe the arising of the coronary arteries in those patients. For cardiac MRI, according to 2018 adult congenital heart disease American guidelines, the CMR is very handy in assessment of the systemic right ventricular dimension and systolic function as a class 2A for initial evaluation and serial follow-up, and we will look for it's easily and very due to very clear endocardial borders, and we can put all the sequences we want. Even in hearts that are abnormally positioned, we can detect the end-diastole volume and end-systolic volume for both ventricles and assess the ejection fraction. And if there is a scarring of the right ventricle by late gadolinium enhancement, can also be detected. And of course, it's very important in post-operative evaluation to check the patency of venous and arterial pathways. And this is just for illustration in which this patient have done an atrial switch. And these are the pulmonary venous baffles, and you can assess the anatomy, it's patent. And this is a systemic venous baffle. And we can also see the velocity sort of the duplex of the Doppler with the color coding, and we can see physiologic stenosis in the SVC or IVC baffle or pulmonary venous baffles. Cardiac catheterization is usually unnecessary. However, if we want to evaluate pulmonary hypertension in case of large VSD and unobstructed pulmonary flow to assess operability in elderly, of course, we can detect additional VSD and preoperative coronary angiography if the CT was inconclusive. And the most important is assessment of what's called morphological left ventricle post-banding to assess adequacy of retraining, and this we will talk about in a slide in a minute. Management of such patients, of course, we see those patients in the adult group, and the usual initial management in the pediatric group is straightforward according to if there is pulmonary stenosis and low blood flow, different kind of shunts to increase the size of the pulmonary arteries and to increase the pulmonary flow, or in the case of unobstructed pulmonary flow and VSD, they are treated like VSD. However, further management needed. So those patients are in heart failure due to the plethora of the pulmonary of the lungs. So they may do like pulmonary artery banding. However, the definite repair is complex case-based process, as we said, because there are associated lesions and because there are a lot of unpredictable behavior in the morphologic right ventricle and the tricuspid valve. Mainly the anatomical repair, which is called double switch repair, and the physiological repair. The progressive TR and morphologic right ventricle dysfunction should be put in position in mind, because this may need a reoperation after the initial repair. Of course, the LV training, if we decided to go for arterial switch procedure, and since the left ventricle is accustomed to low pressure of the pulmonary artery, when we want to make it back again to be the systemic ventricle, this needs to be planned before with different types of procedures to achieve this training. As we mentioned, the systemic to pulmonary shunts like the modified Lvo-Test and bidirectional gland, the physiologic repair, it's not satisfactory anymore because the morphologic right ventricle remains a systemic pump, not accustomed to high pressure, and usually fails and needs, and usually the severe tricuspid regurgitation needs the reoperation and with a high morbidity and mortality. Tricuspid valve replacement is preferred over repair in those cases because usually the valve is diseased and not durable, and it will need replacement eventually. So it's preferable to do TV replacement. LVOT obstruction, different techniques according to the underlying cause. It's very important since we've seen the relationship of the conduction pathway to the VSD, how to avoid the iatrogenic heart block, and the plan for future operation. The anatomical repair remain the gold standard. The atrial switch and the arterial switch with the name double switch, or in case of ventricular and VSD with tunnelable left ventricle to the aorta, we can do what's called as Rastelli operation. And of course, there are special situations that needs treatment as a single ventricle repair, but this beyond the time of this lecture. And of course, the treatment of associated complications like pacing for heart block. The picture on the left side is the operation we mentioned, Rastelli, in which the morphologic left ventricle is tunneled to the aorta, and the pulmonary artery is excised proximally with a conduit, valved conduit connected from the morphologic right ventricle to the pulmonary arteries. This is a less lengthy procedure, of course, but it's not, it have its complications too, and it's more associated with heart block. And at the level of the atria, we baffle the systemic, the superior vena cava and the inferior vena cava into the morphologic right ventricle and the pulmonary veins into the morphologic left ventricle. And the double switch, we do the same as far as the arterial switch. We do the systemic and arterial venous baffles, but we switch the arteries. We excite the aorta and place it at the origin of the morphological left ventricle and the pulmonary to the morphological right ventricle. However, in both procedures, we need to make sure that the left ventricle is adequately trained. Of course, it has been long for a while standing just the pulmonary pressure, especially if there is no large VSD to cause equalization of pressure in both ventricles. So the ventricle goes into a state of deconditioning where its thickness is decreased, and if it's all of a sudden put under systemic pressure, it will usually fail. The idea here is to increase the pressure against which the morphological left ventricle acts, and by creating putting a band over the pulmonary trunk to achieve initially 50 to 60% of the systemic circulation pressure at the time of banding, and monitor the patient meticulously within a year, reaching 80% of the systemic pressure with increase in the LV mass, and possibly doing this arterial switch later on. However, the age for critical retraining remains controversial. It's preferred in younger age, and there's ideas of prophylactic retraining in all patients. Here, the idea of the morphologic right ventricle failure and tricuspid valve when they are in the systemic circulation. The patient who have VSD and dysplastic valve, they have overload of morphologic right ventricle, and this causes morphological right ventricular dilatation, annular dilatation, and morphological tricuspid valve regurgitation, and it's ongoing vicious circle. When the morphologic right ventricle and tricuspid valve are still in the systemic circulation, it's recommended as class 1 to do tricuspid valve replacement for those symptomatic adults with CCTGA and severe TR with preserved or even mild depressed systemic ventricular function. And in asymptomatic patients with severe TR and dilatation or mild dysfunction is class 2A to do tricuspid valve replacement, of course, along with the medical management of heart failure like ACE and diuretics. In patients who have already done a switch operation or Rastelli and they have conduit dysfunction, conduit intervention should be considered for adults, whether intervention or replacement, but you have to recognize a very important thing. When you open the way, it usually patients outgrow this conduit and they develop a degree of stenosis. And this, when it's relieved, the subpulmonary, the subsystemic ventricle will be overloaded again because of the blood flow going to the lungs and back to the systemic ventricle. And this will cause detrimental impact on the systemic ventricle and the systemic AV valve. The follow-up of CCTGA in Gucci Clinic is recommended according to the 2018 Adult Congenital Heart Disease Guidelines. As we see, ECG is mandatory every 12 months, even in physiologic stage A, which is almost asymptomatic patients. Transthoracic echo is recommended yearly. We do Holter monitoring to detect various degrees of heart block because it might be intermittent, especially in transient periods where there is progressive fibrosis. CMR, as we already mentioned, is very important in evaluation of the systemic right ventricle, and exercise testing to detect symptoms in asymptomatic patients is of a value. And pregnancy is usually well tolerated in those patients. However, females with New York Heart Association class 3 to 4 symptoms, moderate or greater AV valve insufficiency or poor systemic ventricular function are of course at higher risk. The risk of congenital heart disease in the offspring of mothers with CCTGA has not yet been defined. The take-home message, CCTGA is complex disease. Variable presentation in the adults may come for the first time, but very rarely, unless they have no associated symptoms. The severity is usually governed by the anomalies and the unpredictable behavior. Advanced cross-imaging like CMR is considered crucial for clinical decision and follow-up. Management is case-based. Physiological repair has proven unsatisfactory strategy, as we mentioned earlier, and anatomical repair offers the best survival in symptomatic patients. Usually the adults present with morphological RV dysfunction, tricuspid regurg, pulmonary artery conduit dysfunction, and conduction defect, and therefore continuous surveillance is recommended even in asymptomatic patients. And thank you.
Thank you أحمد. طبعا فيلد مهم جدا زي ما الدكتور أحمد الجندي أشار، واحنا الحقيقة فعلا محتاجين النولج بتاعتك دهية. أنا مبسوط إنك أنت بقيت متبحر في حاجة احنا في أمس الحاجة إليها. احنا طبعا من عدة أشهر عملنا بروتوكول تعاون مع مستشفى الأطفال في أبو قيش اسم القلب مع الدكتورة هالة أغا، ومن عندنا كان الدكتور احمد عثمان كان برضه اكتسب الانترست في الكونجينيتال هارت ديزيز الادلت من شغله في اسوان هارت سنتر، وبدانا نعمل مشروع مشترك، هم يحضروا عندنا واحنا نحضر عندهم، ونبدا تو ديفلوب السكيل بتاع الجرون اب كونجينيتال هارت ديزيز كلينيك. دكتور احمد عثمان معانا، تحب تعمل كومنت يا دكتور احمد؟
شكرا دكتور محمد على الفرصه. اولا نايس توك يا احمد، كانت محاضره يعني دسمه زياده احمد امين. وهو احنا فعلا كنا يعني عياده الكونجنيتال هي دكتور خالد سرور كان في عياده بيعملها يوم الاحد الساعه 8 الصبح، بس من شهر 10 اللي فات كان دكتور محمد عبد الغني طلب ان احنا وتحت رعايته ان احنا نزود الفلو في العياده، وان احنا نكوبريت اكتر وبطريقه منظمه اكتر مع ابو الريش. فاحنا كان بقت العياده بقت الحد والاثنين، ويوم الاثنين دي يحضر معانا ستاف من ابو الريش، يعني ستاف يعني رشحته الدكتوره هاله اغا. ويوم الاربعاء كنت بروح انا ومحمد ثابت نحضر في عياده البوست اوبرتيف بتاعت ابو الريش، على اساس ان احنا برضه نشوف حالات، وهم عندهم حالات كتير اوريدي جرون اب او ادلت، عشان يبقى في ريفيرال حتى احنا نشوف العيان هناك، ده بيبقى اسهل البيشنت بير سي. وكان في خطوات حتى ان احنا كمان كنا بننفولف الفيزيوثيرابيست اللي موجودين في الاسم، ان احنا نبتدي نعمل اكسرسايز تيست، وان احنا نحاول لو هم محتاجين تريننج او ريهابيليتيشن، وكان في اتجاهات للستارتنج البروجرام ده. وبس يعني طبعا الكوفيد والبانديميك والشات داون ديليد شويه البروجرس في الحكايه دي، بس وي ار موفينج فورورد اي ثينك وذ جود ستيبس يعني. وشكرا دكتور محمد.
دكتور احمد الجندي اسمع يو كومنت.
اولا يعني احمد thank you for an excellent talk في موضوع صعب and rare, and كل مره بنسمع حاجه من complex congenital heart diseases shows us how simple we are in what we do on day-to-day basis when it comes to intervention. As a matter of fact, أنا عايز أسألك سؤالين. One, when it comes to physiologic versus anatomical correction, would the RV function be an important determinant factor? Especially, you know, quite frequently the main reason for surgical intervention would be a concomitant lesion, most commonly a VSD, which is encountered in around 3/4 of the patients. السؤال الثاني, when it comes to anatomical correction, هل في particular preference? I understand data is quite scarce in this field. إنما هل في particular preference ل double switch operation, which is very technically demanding and it ends with multiple suture lines, versus a Rastelli plus an atrial switch, provided the VSD anatomy obviously allows for a tunnel, especially with the view that now with the improvement with percutaneous pulmonary valve interventions, the baffle problems later down the line can be addressed via percutaneously rather than redo surgery زي زمان.
شكرا أساتذتي. وهو ال preference for anatomical repair and especially if done earlier on في the pediatric group ان احنا بنخلي السيستميك ventricle يعني left ventricle يرجع تاني بدري يبقى هو السيستميك ventricle، لان هو ده accustomed على كده، على الرغم من محاولات في بعض الستاديز البسيطه في الفسيولوجيكال ريبير ان هم يعني they do it early on and the patient improve initially, but almost invariably those patients for not the unknown reason, even without the presence of severe tricuspid regurg or severe abnormality, they develop heart failure and it is intractable, and they just say the RV is not designed for this. It's not its work, and they don't know the actual cause or actual reason behind this, and it's not predicted. Some people develop it very early, and sometimes they develop it very late. And in one relatively large study involving 100 patients, around 50% of those patients reaching 30 years of age have developed RV failure. Regarding the second question, the anatomical, the Rastelli versus the double switch, it's according to anatomical governing factors, especially the VSD if it is tunnelable to the left ventricle. And it's not just being tunnelable, there is a high risk in Rastelli to develop subaortic stenosis if the VSD is not wide enough. And this is very serious, and of course the left ventricles rapidly deteriorates. And in other types in which the VSD is not committed at all, it's far from the pulmonary or the aorta, the only solution is to go ahead and do the double switch. So it's according to case-based. Every patient have to be discussed separately according to several factors, but these are the main factors in mind.
Thank you, Ahmed. Again, thank you for an excellent talk.
شكرا.
الحقيقة احنا كده we have to conclude this beautiful webinar مع أسوان هارت سنتر. احنا النهارده we were lucky ان احنا استمعنا ل 3 presentations بدأها الأخ العزيز الأستاذ الدكتور أحمد الجندي. دكتور أحمد ادانا محاضرة جميلة جدا جدا عن السي تي او، وسمعنا الحقيقة كلام مهم عن البروجرام اللي احنا نسمع اقامته ان شاء الله في القصر العيني. دكتوره إيريني كلمتنا عن البروجرام بتاع البلمونري ارتيريال هايبرتنشن، والدكتور احمد امين إليجنتلي كمان ادانا محاضره عن الكوركتد ترانسبوزيشن والجرون اب كونجينيتال هارت ديزيز كلينيك. احيي الزملاء واحيي الدكتور احمد الجندي. الحقيقه احنا سعداء جدا بالتوأمه والمشاركه وحرص الدكتور احمد شخصيا ان يعمل لنا سبورت في اسم القلب في كل المجالات اللي احنا حاسين ان احنا عايزين نكملها. شكرا دكتور احمد وشكرا للمجموعه اللي معاك، ونتمنى ان احنا نراكم دايما في لقاءات مكمله لاسم القلب. شكرا جزيلا.
Always a pleasure وشرف لينا.
شكرا.
تصبح على خير. مع السلامه.
نطلع الصوره ولا